All right, so we're just going to get straight into it. This is going to be an emergency medicine review, and let's go right into it. So the first thing that we hit were really these ESI levels. So I think some of the important things to know here that a pulse ox less than 90 automatically puts you into ESI 1, hypoglycemia in ESI 2, and then we talk about these vitals that are in the danger zone. And really the big ones we look at are pulse ox, heart rate, and respiratory rate, and age as well. I guess just because things change based on age. But I think the important thing here is what's not here. So blood pressure is not there. So that would be a really great question. Which one of the following is not a danger zone vital? And that would be blood pressure. All right, so just keep in mind heart rate, pulse ox, and respiratory rate. All right, so I think knowing simple lax is in ESI 4 is important. These are things that require one type of resource. So, sutures or an X-ray or, things that you kind of have to do procedures for. Whereas for ESI 5, I think it's like dental infection. I think you just consult dental, like med refill, suture removal, like whatever. And then for ESI 3, I think knowing the difference between 2 and 3 are that vitals are going to be stable in 3. They still need urgent attention, but their vitals are fine. And you need more than one resource. So lightheadedness, they're going to need a workup for that, abdominal pain, joint dislocation. They're going to need some imaging. They might need to have their joint reduced. They might need medication for that. So that kind of all makes sense. And then, of course, if they're just unresponsive, they would be in ESI 1. So that's really it for that first PowerPoint. We're going to go right on to Airway. Obviously, knowing that only an ET tube can reliably deliver 100% O2 is important. I don't know if they'll go into this detail, but really your first step in oxygen is going to be a nasal cannula. So that's going to cap out at about 6 liters in terms of your flow rate. Because really, when you get higher than that, you're going to want to use something else like a non-rebreather. But the nasal cannula, even up to 6 liters, is only going to deliver about a quarter to just under a half, so 25 to 44% O2. A non-rebreather mask, there's some other ones in the middle, like a plain normal mask. I really don't think those are important. But a non-rebreather mask, the one with the bag that doesn't allow you to breathe in any of the environmental air, that's going to go up a little higher in terms of the flow. So that's usually going to cap out at about 15. And even with a tight, proper fit, that's only going to get 95%, okay? So a CPAP machine is going to be used for patients with sleep apnea. I don't think they're going to ask about that. That's continuous positive airway pressure. BiPAP, that's where it's at. That's what you're going to use in like EMS in the emergency room. This you can fine tune like your specific inspiratory and expiratory pressure. And if you subtract EP from IP, you get the tidal volume. You can also set a respiratory rate with that as well. So BiPAP is going to be the one you want to use for things like CHF exacerbations and COPD and asthma. So yeah, just a good airway option there if they're not like crashing, but their pulse ox is low. And they're in like some type of respiratory distress, probably skip the nasal cannula, like go right through BiPAP, right? If they're really working, it would probably be pretty clear in the vignette if they're having an exacerbation, right? Okay, so indications for intubation, severe respiratory acidosis, inability to protect airway, that's the big one. So GCS less than or equal to 8, or if they just, for whatever reason, can't cough or can't clear their secretions. Just because they can gag doesn't mean that they can protect their airway. GCS, just kind of real quick. So, you have your EVM and your 4, 5, 6. Somebody had said, and this actually stuck with me, that like McDonald's, the everyday value meal, so EVM costs $4.56. So just getting EVM in a row and knowing you start at 4 and go up +1 is pretty helpful. Just know that your minimum is 3. And eye openings, like some of these are like pretty self-explanatory. The verbal one I think is interesting. You might get tripped up on these early numbers, but a 2 is they're making noise, right? They're making some type of sound, they're moaning, but it's not a word, they're making no sense, right? 3 is they're just saying nonsense words. It has absolutely nothing to do with what anybody's talking about, but they're words, they're saying words. 4 is going to be really like in response to a question, like if you say, do you know where we are? And they say home, but they're in the hospital. Or if you say, is this an apple? And they say that's an orange. Like they're close. They kind of know what you're asking. So they would get a 4 if you say, where are you? And they say cheeseburger with fries. It's great that you said words, but you're going to be a 3 for that. Okay. And then the big thing with motor response, it's going to be that decerebrate posturing is that extension. You're kind of giving up at that point, sadly. So you're at 2. And then decorticate is more, it's corticate towards the cord. You're more protecting yourself. So that's better. So you're going to get 1 more point. And then 4 is going to be, if you do like a trap squeeze or something and you kind of just like withdrawal away, that's going to be the 4. And then a 5 is going to be you do a trap squeeze or sternal rub or whatever, and you actually push. You know exactly where that pain is coming from. You localize to it, and you usually like swat somebody out of the way. So that's going to be a 5. Number 1 cause of obstruction in the breathing patient with reduced level of consciousness is going to be laxity of the tongue. All right, so then you have these 2 methods here. Just know that the head tilt chin lift is going to be the one that is preferred unless there's a possible C-spine injury. So this is the most common one that is used, was you could tell you're pushing downward on the head. So that's not going to be good for the cervical spine. And then the jaw thrust is going to be the one that you want to use when you suspect some type of C-spine injury. All right, so you're putting the thumbs on the chin and then the angles of the mandible grasped with the remaining fingers, and you're still lifting the mandible anteriorly. All right. All right, so the NPA versus the OPA thing, I think, and this was on the NREMT for EMS, NPA is always for somebody who's like semi-conscious. So it is used for conscious patients, but they're not going to be like completely awake and fine and you're shoving them in their nose. Like something is going to be going on, right? It's going to be some type of trauma or some type of like overdose or something. But they're awake, they're conscious, they're kind of higher up in the GCS, but like something's wrong. So, they do have to be conscious, but just kind of look for that on a scenario. So you're going to size this from the tip of the nose to the ear lobe. You don't want to use this with signs of basilar skull fracture. So you can see those listed there. Now the OPA, that's what's going to be used. So the oropharyngeal airway is used for unconscious patients, okay? Because you can't shove something down somebody's mouth like and like torque their tongue with it if they're conscious, right? So they must not have an intact gag reflex, because if they do, they're going to vomit. It's going to go all over. They're going to aspirate. You don't want to do that. So this is just sized from the corner of the mouth down to the angle of the mandible, kind of when you're lying down. You can insert, there's a couple different ways you can insert it, but I think most commonly it's upside down and then you rotate it, and it's just going to hold your tongue in place. The big important thing here is, and I think this could be on a question of, they tolerate an OPA. What is your next step? The next step is going to be intubation, right? You just shoved this into their mouth. They clearly are not conscious. They clearly have no gag reflex. They have no control over their airway. So they're going to require an ET tube. Eventually, OPA is just kind of your stopgap to get to that point, okay? You want to use a rigid Yankauer suction for the oropharynx. So when you're getting deep into the throat, no longer than 10 seconds. And it's important to know you want to provide pre-oxygenation and post-oxygenation before you do the suctioning. All right, so 10 seconds is a max there. Just in general, they mention this all the time. The BVM is the most important skill in effective airway management. So not intubation, not endotracheal tubes, nothing with any of this other stuff. It's simply just the BVM. Because if you're not able to use that, it doesn't matter if you have a secure airway because you're not ventilating them, right? So there's this thing called ramping. You want to make sure you have ear to sternal notch. That's going to be important. A lot of great things. It lengthens the apnea time to critical hypoxia. So that is a good reason to do that. Maximizes the quality of the view during intubations. Oh, I'm sorry. That's for ear to, yeah, for ear to sternal notch. Forgot what I was talking about for a second. So yeah, you just want to get that airway open. I guess know when ample stands for. I don't know, kind of self-explanatory, but you want to do this prior to intubating, right? Are they allergic to the sedative or the paralytic that we're about to give them? Are they already on some type of medication like a benzo or something? So that's going to be important. Yeah, this I thought was cool is that there's this point about you can assess the ability of ventilation with the BVM before you paralyze and intubate them. So you want to see, do you have equal chest rise? Is there some type of paradoxical movement? Is there something else going on? You have the BVM, they're not paralyzed, they're still there. Before you give them any med, kind of see what kind of response you get. So I think that was kind of an interesting thing. All right, there's this thing called nasotracheal intubation. You can use this if oral intubation is contraindicated for whatever reason, or you don't have meds, or maybe they're allergic to meds. They have to be awake and sitting upright. I don't know why would you even be talking about oral intubation if they're awake? I mean, I guess, yeah, you don't have to be unconscious. You could have a low GCS and still be like technically conscious. Yeah, this is like an interesting one. But as you put it in proximal end, when you hear the breaths the loudest, you advance on the next inspiration. I think about that as like it's helping the tube go in on inspiration. Bevel rests against the septum. Again, anything with touching the nose and there's basilar skull fracture, just don't do that. You also can't do this if they're not breathing, just like with an NPA, right? They have to be conscious, which means they're breathing, right? So oral intubation, that's where it's at. This is your RSI, your rapid sequence intubation. There's this lemon rule. So L is just look. E is the important one. I'll see if I can remember this. So this is with assessing a difficult airway. So you want to make sure you can fit 3 fingers. I was talking with somebody about this, like your fingers, the patient's fingers, because if it's like a child or somebody that's small or big, like, are you taking the patient's finger? Like anybody could shove their fingers into someone's mouth. It's kind of arbitrary, whatever. So 3 fingers you want between the teeth, and then 3 fingers you want between, I believe it's the jaw, like the edge of the mandible here, and then the hyoid bone, right? And then it's 2 between the hyoid bone. Is it the cricoid? Okay, the thyroid notch. So 2 between the hyoid and then the kind of your Adam's apple, right? Is the thyroid notch, I think. Malampati, just know 1 is the best, 4 is the worst. That's your ability to visualize the uvula. Obstruction, so you want to see, do they have something like epiglottitis? Is there stridor? Is there drooling? Is that going to be a difficult intubation? Neck mobility, they totally could tie into something from rheumatology. So if they have rheumatoid arthritis, they could potentially have that atlantoaxial subluxation of C1 and C2. So they would need an X-ray before you go ahead and shove a tube down their throat. They could have ankylosing spondylitis as well. So things to consider. Then we have another mnemonic. We have this soap me. They always talk about this. Make sure the yank hour is under the patient's right shoulder because the intubator is most likely to be right-handed. They could totally throw a left-handed provider into the scenario. I think that'd be really interesting. So don't tunnel vision into that. Oxygen, airway equipment, position, monitor, end title. They talk about this straight to cuff where you want to have the tube with the stylet straight all the way to the cuff, and then you bend it to 35 degrees. Macintosh, I think of like a Macintosh apple is curved like a round apple, and this is going to be the one that indirectly elevates the epiglottis. Miller, I think of like taking like a Miller Lite, just like drinking it straight. So that's going to be the straight one. So straight, it's more direct. It's going to directly lift the epiglottis. It's also the one you use for pediatrics. So I think of like if you gave a beer to a kid, then it would help sedate them. So that's why you want to use the Miller. All right, yeah, this video is not going to get monetized. All right, so then we have this sniffing position, which is about the extension of C1, C2, but everything else is flexed. So this part is extended to open the airway, but then your neck is kind of flexed forward. So it's called the sniffing position. That plus the ear to sternal notch is like your gold standard for positioning. This is important, definitely going to be a question. You want to pre-oxygenate. It says with a non-rebreather and a cannula with 100%, so turn all the way up for 3 minutes. 3 minutes, wait for that O2 sat to get up to 100. Do that for 3 minutes. And then when you have all your materials ready, then you can, take off the BVM and start working with your intubation. Look for reasons that desaturation could happen. Okay, so now we have the medications. Just know that etomidate is what you start with, right? This is your sedative. This is your induction agent. It has no effect on blood pressure. So if they're crashing and you're afraid this will make them even more hypotensive, you don't have to worry about that. It does lower intracranial pressure. I don't know why that's that important. I guess if they're at risk for herniation and you need to give them etomidate, that's a good thing, right? Although you give them mannitol for that. So I don't know, just know it lowers intracranial pressure, has no effect on blood pressure. They always talk about this transient adrenal suppression. I don't know why that's important. I don't know how transient is transient. So keep that in the back of your mind. If they're, I don't know, if they're already having some type of like adrenal insufficiency, maybe you don't want to give them that. All right, so then we have the 3 paralytics. So after we give them the etomidate, we have the 3 paralytics. So succinylcholine, or SUX, is the only depolarizing agent here. It works quickly, so 45 seconds. You're going to have about 5 to 10 minutes to do what you have to do. So I think of SUX like succinct, so it's short acting and short lasting. The big contraindication here is with hyperkalemia. The way I think about this is it's a depolarizing agent, right? And you think about an EKG, when you get height over the isoelectric line, is that even what that's called? That's depolarization, right? So if they already have peaked T waves because they're hyperkalemic and you give them a depolarizing agent, it's just going to make those waves go higher. I don't know if that's how that works, but that's how I remember this. Makes sense to me. So that's the contraindication there. Okay. And it can bump your K up by up to 1. So pretty crazy. All right. Now, rocuronium and vecuronium are your non-depolarizing agents. These work on acetylcholine. I think of rocuronium as R for receptor, because this is going to block the acetylcholine receptor and inhibits the parasympathetic nervous system. Vecuronium is going to just block acetylcholine release. I don't know that there's anything else. You don't want to use these in patients with a difficult airway. I don't know. I don't exactly know why, but just don't use that with a patient with a difficult airway. All right. Then you have this curved blade, laryngoscopy, this burp. If you're doing this, it goes into the right side of the mouth. You sweep the tongue to the left. You want to indirectly lift the pharyngeal wall. You never want to lever because you'll avulse some teeth. Bimanual is really the gold standard here. It's the most effective, most practical technique for ensuring first pass intubation. Epiglottis is always the first thing that you want to look for. And then on an end-tidal CO2 detector, which goes between the BVM and the ET tube, you want to look for yellow to know that some seed O2 is coming out and that you are properly ventilating them. All right, so this is definitely going to be a question. So the ET tube should be 3 to 5 centimeters above the carina or midway between the thoracic inlet slash outlet, I guess inlet, which would be T1, so right where the thoracic vertebrae start, and the carina. So midway between the thoracic inlet and the carina, or 3 to 5 centimeters above the carina. All right, so that could definitely be a question. It's like, well, what do you do next? All right, you pull it out or you push it in a little bit more. Once you have an ET tube in, you can administer medications. I thought this was pretty cool. So this spells lane. So you could do lidocaine. So think about if they're in some type of dysrhythmia, atropine, if they're bradycardic. Unless it's you don't want to give that for hypothermia, right? That's not going to work for hypothermia. You could do Narcan and then you could do epinephrine. So just think about situations where you might have to administer those. All right, then we have these airway adjuncts. You have the glidoscope. That's the one with the video. It's the one you want to use with a suspected C-spine injury. So definitely could be a question there. This is going to be inserted midline. So you just glide over the tongue, I guess. Bougie is the one. I think the important indication here is to replace tubes that are like too small or damaged. And they talk about this like bouncing off. It can be introduced blindly. You kind of follow, I guess, the ET tube that's already in there with this. But I think if you need to replace a tube, go for the bougie. The light stylet is cool, kind of self-explanatory. These two, I think just knowing these are supraglottic airways, like these aren't definitive. They're kind of like last ditch efforts, probably before you can do like a cricoid or go to the OR or something. It's the laryngeal mask airway and then the king airway. So these have these cuffs. The king airway, king is like more superior. So it has these like massive cuffs. It's crazy looking at that. And this one has this little piece here that kind of sits over the like esophagus. It occludes the esophagus. So it has the elliptical cuff. All right, moving right along, procedural sedation, light and moderate. That's where we want to go for intubation. Deep, we went too far. Airway protection is impaired. The patient requires repetitive, painful stimuli to respond purposefully. That's not good. General anesthesia, obviously, we don't want that we don't want that at all. Went way too far. They never mentioned this. I don't think we have to know this. The American Society of Anesthesiology. Less than 1 month, greater than 85, give them a call. Complications from sedation usually occur like within 5 to 10. So if they're going to have some type of med reaction, it's going to happen pretty quick, or after the procedure when we're not delivering any stimuli like touching their elbow or repairing a lac of their labial artery near their lip or something. So that's good to know. You're not out of the woods yet until you've monitored them for a while. All right, so meds for procedural sedation. We'll try to get through this pretty quickly. Benzodiazepines, midazolam or Versed is going to be the one of choice. All of these you push slowly. This, I think, is important. If you need to give another dose after like 3 to 5 minutes, you can give them a repeat dose, but it's 25% of the initial dose. I think that's important. If you do combine it with an opioid, you decrease your, I think, overall dose by 1/3. That's pretty important too, I think. So you cut it by 1/3 if you're going to put an opioid in. All right, the reversal agent, they always talk about this. So flumazenil, you basically don't ever want to give this to anybody. That seems to be the name of the game here, but especially not for somebody on long-term benzodiazepine. So kind of think about what a patient, what a vignette could look like for somebody who could potentially be on long-term benzos. You don't want to give it to anybody who already has an underlying seizure disorder, right? Because you're going to give them a fatal one. The MOA, so this potentiates GABA's inhibitory action. So GABA is already an inhibitory neurotransmitter. So it's basically a GABA agonist, I would think. And, it's going to have anxiolysis because it's a benzo, but it's not, there's going to be no analgesia here. So it's going to do nothing for the patient's pain because, this is a, kind of a, like a depressant overall. So it's going to cause respiratory depression, hypotension, because it's slowing everything down. All right, so opiates and fentanyl. So fentanyl is going to be the one of choice. This is the one that is going to be able to give the patient some analgesia, some pain relief. Know that it's dosed in micrograms. So look for that MCG. It's really important, especially for kids, right? Associated with apnea, if you give them too much, lowers blood pressure, but not by much. You can get nausea and vomiting. But I think the important thing here is if you give it too fast, again, I mentioned you want to give all of these slowly. If you give this too fast, you can cause chest wall rigidity. So probably not good for breathing, right? And you cannot reverse that with naloxone. So know the overdose triad is meiosis, altered mental status, and respiratory depression. Yes. Yeah. Okay. Yeah, and we'll talk about this in a second, but opiates are stimulating your parasympathetic nervous system, right? The rest and digest, and that is going to come with meiosis, with pinpoint pupils. It's like the body's kind of going to sleep, it's resting. On the opposite side of that, when the sympathetic nervous system is stimulated, your eyes are wide open because you're fighting somebody. You need to be able to see. So we'll talk about that in a bit when we talk about overdoses. All right, etomidate. This is going to be ultra short acting. We talked about this as a sedative. It's also classified as a hypnotic, which is pretty cool. This is going to be recommended just for brief procedures. We already talked about it. It's an induction agent for RSI. It can result in muscle spasms. So think as like, as it's trying to sedate the body, I don't know, you spasm out a little bit. So if you're trying to do a reduction of a dislocation, maybe not the best thing. You also use this for cardioversion for things like VTAC. I wonder if you use it for, like pacing too. All right, propofol is a good one that you want to use for dislocation reduction. But I mean, you could use Versed for that too, right? Look for hypotension, and it can rapidly result in a deeper sedation state than attended. For peds, ketamine is going to be the big one to know here. They get this trance-like cataleptic state with some like amnesia. Some considerations here are you get an increased skeletal muscle tone. So I guess be careful if you're using this for like a reduction of joints or something. I guess you would use this more for like lac repairs or like foreign bodies. And it does some weird things. So it's going to increase your bronchial and salivary secretions. So bronchuria, that sounds very cholinergic. Yeah. It's like a killer bee. Yeah. And it's going to increase heart rate and increase blood pressure. So I think that's a pretty interesting thing for something that's such a strong sedative. It's going to increase blood pressure and heart rate. So despite it being a sedative, it has some pretty interesting nervous system activity, especially with the, the skeletal muscle tone. So keep that in mind. Fentanyl, again, chest wall rigidity. It comes as a transmucosal lollipop. I thought that was really interesting. Sounds extremely dangerous. All right, now we go into legal issues. No civil law is the one that we're going to be, succumb to for alleged medical error. Monetary compensation is the end goal there. The four elements, duty to treat. So like EMTALA, were you responsible in the first place? If it's the Good Samaritan law, there really was no duty to treat there. So breach of duty, was there some type of negligence? Was there actual damage done? And then direct and proximate cause, was that alleged breach of duty the cause of the damages? And that's the most difficult to establish. All right. Most common medical malpractice claim is missed fractures and dislocations. Pretty interesting. That's why you always splint. Statute in PA, I don't think we need to know this. It's about 2 years. But the clock starts ticking when the person identifies the malpractice, not when they were in the hospital. I don't know if this is going to be a question, but we should definitely know this. So the legal limit of alcohol in PA, and I think most places, is 0.08 or 80 milligrams per deciliter. The really important thing here is that it's metabolized at about 20 milligrams per deciliter per hour. And the goal for somebody who comes in like with a 0.24 is not to get them to zero. We actually just want to get them to the legal limit. And then they're able to be discharged. So that could be just like a pretty easy math problem that they could ask. So just remember 20 milligrams per deciliter per hour, and then just kind of subtract from there to see when you can send this person home, but get them to 80, not to zero. Yeah, emancipated minors. Sometimes the provider has to assume temporary custody for life-saving treatment for their child if a parent is refusing. So that's pretty interesting. You don't just let them die. You actually kind of just take matters into your own hands. All right, let's talk about trauma, and then we'll get into like the really fun stuff. So they talk about these 3 peaks of trauma. So the first one is just the patient dies at the scene. The only thing you could do with this is prevention. So there could be a question that says like, hey, what do speed limits or like seatbelt laws, what peak of trauma are they trying to prevent? That's going to be the first peak. The second peak, the golden hour, I guess this is because, these are things that we can fix. These are things that we can prevent. This happens within minutes to hours. And they spell the affectionate mnemonic pee-pee shit. So it's going to be like a pneumothorax, a pelvic fracture, splenic laceration, on the other side, a hepatic laceration, an intracranial bleed, and then a pericardial tamponade. So what's interesting is that this hits 4 of the areas you could do for a fast scan, right? So because it's kind of like across. So it's the pelvic fracture, the spleen lac, the liver lac, and then the pericardial tamponade. So all areas you could hit with a fast scan, and then just think a pneumothorax, which you'd have to shoot an X-ray for, and then an intracranial bleed, which you would have to do a CAT scan for. I actually like that. It's a good way to like remember these. I mean, I guess they're kind of self-explanatory, but I like how you can potentially rule out 4 of these with a fast scan. Cool. There we go. And then the third peak is what happens, days to weeks later. So they develop sepsis or like kidney failure or ARDS or something. All right, trauma primary survey says A, B, C, D, E. So airway with C-spine. Again, the laxity of the tongue comes up. Hypotension following trauma is going to be hemorrhagic shock. This, I think, is important. So reduction of blood pressure does not occur until at least a third of your blood volume is lost. That is a lot of blood. So this is a late finding. You're going to see tachycardia much sooner. So you're going to see the body compensate for that loss of volume. So that's probably actually more important than the blood pressure. Because if you see tachycardia and there's really no other reason for it, then they're hemorrhaging somewhere. Disability, this is only a primary evaluation. The rest will come in the secondary survey. Cover them with a warm blanket following exposure. Yeah, we always did that in the trauma bay. Ample allergies, meds, past medical history, and pregnancy. You want to turn the patient on their left side so that they can breathe easier, get the fundus out of the way. It also opens up, I think what we learned in EMS was, the right lung is usually larger, right? It's the one with 3 lobes because the heart's more to the left. So you're kind of pushing everything to the left and letting the right lung do more of the breathing. I don't know if that's the case. Yeah, all right. I had to just make sure I knew the right lung had 3 lobes. Okay. Posterior hip dislocation. So that's going to be, so if it's a dislocation, that's going to be internally rotated, right? Internally rotated and adducted. Yeah, okay. And then a fracture is going to be shortened, externally rotated, and abducted. So look for that. Posterior hip dislocations, look for this in motor vehicle dashboard injuries. So we have the nexus criteria. Let's see if I can remember this. So this is posterior midline neck pain, focal neurologic deficits. They're like drunk or potentially having a stroke or something, some type of altered mental status, or they're under the influence. And then the last one is, gosh, what is the last one? Midline neck pain, focal neurologic deficits. They're not under the, oh my gosh, I can't believe I can't remember this. Oh, no distracting injuries. Whew. Okay, so no distracting injuries. So yeah, so for this, like no posterior midline neck pain, you have to palpate that. So you have to open the collar. Focal neurologic symptoms, could mean there's a spinal cord injury. So you probably want to send them over to CAT scan for that. No distracting injuries that could be so painful that they don't know if that their neck is in pain. But if they clear all 4 of these, you're still not out of the woods because you remove the collar, I guess you palpate again, and then they need to do active range of motion. If they cannot do that or they have pain with doing that, you can't clear the collar. So I think that's really important. So you got to send them over to CAT scan or if not, MRI. All right, we'll try to go through these. Scalp injuries, you can staple, you can use the hair apposition technique. Skull fractures, they made a point of mentioning this for a depressed skull fracture. I mean, that doesn't look good, right? So not only do they want a CT, but you want to do a neurosurgical consult. Again, look for the signs of a basilar skull fracture. If it's open, if there's skull popping out of their skin, give them IV antibiotics, right? You probably want something that would nuke Staph aureus, so some type of gram-positive. I don't know that you'd give them Vanco. You probably give them like cephalexin, right? Like a first gen Ceph to cover the gram-positive. All are diagnosed with non-contrast CTs. Yeah, so any type of skull fracture, anytime you're ever looking for head bleeding, it's going to be a non-contrast CT. Diffuse brain injuries, mild concussion to severe hypoxic ischemic injuries. CT is going to be normal. It can include loss of consciousness, but don't freak out. The other thing too is if there's hypoxia or ischemia, like after a code or something, the initial CAT scan may be normal. So something to kind of keep in mind. It can occur in any part of the brain, mass effect, whatever. All right, this I think is really important. So the Cushing's reflex, the triad of intracranial pressure. I'll see if I can recall this from memory. So what happens is after head trauma, if there is, an increase in intracranial pressure and you're like herniating or about to herniate, you don't have enough perfusion in your brain, right? So what does the body do? It raises the blood pressure. So it's going to peripherally constrict. It's going to shunt blood up to your head to perfuse your brain. As it does that, it rushes up all of the baroreceptors, like in your carotid sinus. And the baroreceptors are like, that is a lot of blood pressure. We should probably slow the heart down a little bit. And that's what it does. So that's why your heart rate goes down. And then while all of this is happening, as your body is shunting all of this blood into your head, your intracranial pressure is increasing and your blood pressure is increasing, your brainstem is getting mad stressed out with all this extra pressure and is actually affected. And the brainstem, the medulla is what controls breathing, right? So you start breathing slower. So the triad here is going to be an increased blood pressure, specifically the MAP, a decrease in heart rate, because again, those baroreceptors sent those messages to the heart and said, you need to slow down. So that's probably vagal stimulation. Yeah. And then you get those irregular respirations. So I thought that was pretty cool. To fix this is also pretty cool because you use either hypertonic saline or mannitol. So because they're at risk of herniating, you need to get fluid out of the cells in their brain. So how do you do that? You give them mannitol or you give them a hypertonic saline. So you load their blood with salt. Water's going to follow the salt. So the fluid is going to come out from the cells, out from the interstitium, come into the bloodstream. Then it's going to go down to the kidney. It's going to get, it's going to go through the glomerulus. It's so salty that the gradient is favoring, the collecting duct, the tubules at that point, and you're just going to diurese it out. So it's a diuretic, but I think the way it works is pretty cool. And I said here, yeah, you're literally urinating out fluid that was in your brain. So there you go. And it can reduce intracranial pressure. It only takes 15 minutes to work. I thought that was pretty cool. One of the downsides, though, since you're flooding their bloodstream with fluid, is pulmonary edema. So your heart could kind of get a little bit overworked and you could have a buildup in your lungs. Okay. Subdural hematoma. So this is going to be the one that you see kind of more in the elderly, right? This is going to do with those bridging veins that kind of get weak and like sclerotic over time. I think an interesting symptom here is a personality change. You'll see this as a crescent shape, so subdural. So this is going to be between the dura and it says brain, but it's like arachnoid matter, right? Dura is the outermost covering. So, of course, neurosurgical emergency. That's acute from like a fall or something. I mean, you could get an epidural from a fall. But there's the subacute. Oh, you'll get this with elderly on anticoagulants. So it's just kind of a spontaneous head bleed. So it's going to be more insidious. They might have headaches, cognitive dysfunction, ataxia. It could even mimic Parkinson's. Yeah, and it's those bridging veins, and that's why it's called a subdural. It's the bridge between the dura mater and the arachnoid mater. So that's why it's called subdural. All right, the epidural hematoma. I think you see this more with trauma, pretty sure, right? It's going to be an injury to the middle meningeal artery. Yeah, from an overlying fracture. So you can see this more with trauma. So middle meningeal artery is going to be the one that gets affected there. This is going to be, I don't know if I said crescent shaped here. This is going to be the lens or football shaped one. And then you can also get a midline shift. So this is kind of between the dura and the skull. I think about this of like the skull is so solid, it's going to leave no room for anything. So that's why you're going to get more of this midline shift. And probably because it's an injury to an artery. It's not like a bridging vein issue. This is, I assume you get more blood with this one. So this is going to be a lot more sudden, but you do get this lucid interval. So I guess the trauma would happen. You're fine, you're lucid, and then it just deteriorates from there. So another neurosurgical emergency with the epidural. All right, nasal fractures. These are the number one facial fracture. You want to make sure you do an I&D because they can cause necrosis. You can give them some decongestants, which will be vasoconstrictors, right? Right? Yeah. Lefort, apparently we do not need to know. I mean, I guess know a tripod fracture is a thing, and you want to do a referral specifically to oral and maxillofacial surgery. Give them antibiotics, give them a CAT scan. Mandibular fractures, I think an important thing here is that they break in at least two places. So if there's a vignette and says, hey, you see a fracture in their jaw, what's your next step? And the answer is going to be look for another one because there's probably a second one. And then there's this interesting part too with if you give them a tongue blade or like a tongue depressor, they can hold it between their teeth. When you pull on it slightly, it makes the diagnosis highly unlikely here. You probably, I guess you would, I actually guess you would not do a CAT scan. And then it says you want specific antibiotics to cover oral mouth flora, which I thought was more like Eikenella, yeah, which is gram negative, but we're using penicillin or clindamycin. Pretty sure, like, I mean, penicillin is definitely gram positive, but clindamycin, I'm pretty sure is more gram positive too. So I'm not exactly sure what's going on there. I guess you're still concerned with staph aureus if there's stuff happening on the skin. That's what's happening. It's not an injury inside of the mouth. I don't know. I'm making things up. All right, you have this penetrating neck trauma. I think 2 is the big one here. That's the one that requires exploration. So it involves more of the platysma that's between the mandible and then the cricoid cartilage. So not thyroid. So it goes a little bit lower than that to the cricoid cartilage. So look for that. All right. Then you have the cervical spine trauma. So there's this swimmer's view that you can do with the contralateral arm upwards and the ipsilateral arm downwards. So it gives them more space to look on the x-ray because I guess, yeah, like my shoulder actually drops a little bit just doing that. And then you do this and it gives you a little bit more space. A disruption of 2 or more of these 4 columns is going to be unstable. So you have the anterior, the posterior, this spinolaminar, and then the posterior spinous. Spinal cord is in the middle column with the posterior, with the PLL, the pedicles, and the transverse process. On films, you want to see from C1 up here to the top of T1, which is right there. 1, 2, 3, 4, 5, 6, 7. Yeah, so that's a good view. I mean, this is a little cloudy here, but unstable C-sign fracture. So the most common C1 fracture is the Jefferson burst fracture. That's the one from like an axial load on the head, right? And the best way to see that is with an open mouth odontoid view, right? So the C1 is not, C1 is not where the odontoid process is, but it's you can look through that to see it, right? And I think that's why C1 kind of sits on top of, it rotates around the odontoid process, right? Also known as the dens. That's what kind of allows you to do, that's what allows C1 and C2 to do this, because C0 and C1 does this, and then C1 I'm rotating around my odontoid process. This is C1 and C2. So opening my mouth allows me to see C2 and allows me to see the odontoid. Yeah, because I guess it's still a C1 fracture, but you're not going to be able to rotate around the odontoid. I don't know. I'm probably overthinking this. Type 1 is just the tip. Type 2 is the neck and the base. Type 3 is the body for the odontoid fractures. It's held in place by the transverse ligament. Flexion teardrop and bilateral facet dislocation, no good. These are associated with neurologic injuries. Yeah, I mean, that doesn't look good. A little teardrop coming off there. It's like whole thing is slid off. That's not good. Spinal subluxation, that doesn't look good. Stable ones are the wedge. So this almost looks like, actually it looks exactly like that, doesn't it? The teardrop, buccal anterior cortex, whatever. Simple wedge is fine. Clay shovelers, you're fine. Isolated fracture. I mean, it's like all look the same. That looks pretty bad. All right. Anyway, clay shoveler is stable. You can get this thing called a chance fracture. This is an unstable, it's a transverse fracture. This happens in the lumbar and it's through the vertebral body. Look at this. This whole thing is crushed. And you'll see it with the patient only wearing a lap belt. I thought this was like an old car that didn't have a shoulder harness. Maybe you're in like the old middle seat, or it's just somebody who is not wearing the shoulder part and is just wearing the lap part. Skin ulcers on a backboard can develop in little as 1 hour. Normal like bed sores on a soft surface are 2. So I think that's pretty interesting. Yeah, increase for aspiration. You can't breathe when you're on a backboard. Oh, all right. Tension pneumo, look for that contralateral tracheal deviation. You know, if you have a pneumothorax, let's say on my left, it's going to push all of my vessels to the right. It's going to move my trachea to the right. So you'll see that contralateral tracheal deviation. You're going to do a needle compression mid-clavicular line, second intercostal space, which is below the second rib. Yeah, just above the third rib. So you're in that second intercostal space, but stay away from that second rib because you want to be right on top of the third rib so you avoid the neurovascular bundle. And remember, just the definition of a tension pneumo, kind of despite the MOI, is just a hemodynamic instability. Open is going to be your sucking chest wound. You want to do a 3-sided flutter valve. You know, you don't want to cover this completely because they're breathing through that hole. And you also don't want to shove a chest tube into it. So you want to do the chest tube remotely. Simple pneumo. This, I think, is really important. It's going to be accentuated in expiration. So as you're inspiring and your lungs are filling with air and getting bigger, it's going to inflate that like simple pneumo, right? But when you breathe out and the lungs shrivel, then you can clearly see that pleural line here on the right. Hemothorax, massive, defined by greater than 1.5 liters. They usually don't ask the questions for like the amounts for these, but they'll need a thoracotomy if there's greater than 1 liter in there. Don't we only have like 6 liters of blood? Right? Don't we have like 5, 6, 7? How many liters? Yeah, like 4.5 to 5. So if we've lost like a quarter of our blood is in our lung, then yeah, I would say you would need a thoracotomy. But massive is greater than 1.5. Flat chest is defined by 3 or more adjacent ribs fractured in 2 or more places. So 3 or more, and they have to be adjacent. It's so specific, isn't it? Fractured in 2 or more places. Okay, you're going to see that paradoxical chest rise, 3 or more in 2 or more places. Yeah, because I guess just one fracture isn't going to have paradoxical movement, but you have 2 or more places and there's like just a piece of rib not attached, you're really going to see some paradoxical things with that. Patchy infiltrates for a pulmonary contusion, given incentive spirometer, cannot differentiate from pneumonia. So ask a good history. Rib fractures are the #1 injury seen in blunt chest trauma. Don't tape the ribs. Sternal fractures, do an EKG. The heart is right behind the sternum. You need to see this on a lateral view, which I think is really important. So you can't do an AP view. Here's that fast exam we talked about. So again, it's kind of like a cross. It's the pericardial window, and then down south to the pelvic window, and then to the west, east, whatever, the perisplenic, and then the perihepatic. So the liver one is Morrison. Morrison sounds like a whiskey or something. So think of that as the name of the liver one. So that's how you know that's the liver. Free fluid is going to be black, seen on the right. Yep, so that's free fluid. So that's not good. Do we know it's blood? No. It could be anything. We just know it's some type of fluid. So they probably needed a CAT scan, yeah? Look for left upper quadrant pain. So Kerr's sign is going to be for that splenic injury that rotates up. Liver is the most common organ injured in stab wounds in the abdomen. Makes sense. It's a solid organ. It's massive. So that seems logical to me. That can also radiate to the right shoulder. So urethral, I think what's important with this is that if you have a high riding prostate, so think P prostate and P for posterior, you're going to have a posterior urethral injury, like a urethral tear. The anterior is going to be more from like a straddle impact, but I think it's actually all P, pelvic fracture, high riding prostate, posterior urethral injury. So I think that's important. If you see bad stuff like the inability to urinate, bloody meatus, etc., do a retrograde urethrogram before you shove a Foley up there. That seems logical. You don't want to see contrast extravasation. Yeah, you don't want to see the contrast you gave them leaking out into their body somewhere. If you do, they're going to need a suprapubic catheter. For a bladder rupture, you do a CAT scan first before you do cystography. So look for on a vignette somebody who just left a bar with a belly full of beer getting into a car accident, renal injuries. Oh, so retroperitoneal. So I kind of skipped over this. So that's important. The fast scan is useful. However, it's not good at seeing things like can't see the pancreas, right? Can't see the pancreas. You can't see the kidneys. Those are like the big ones. So a CAT scan is going to be better for pancreatic and for kidney issues. So if they have flank pain, or if they have the Cullen sign, and I mean, that's totally going to be a question, right? They have Cullen sign, they have Gray Turner sign. What imaging modality is going to be best, or what imaging modality would not be great? And the answer is going to be ultrasound, right? You want to go for a CAT scan for that. So then, yeah, kind of reminded me there of renal injuries, retroperitoneal. So you want to do a CAT scan. And with contrast, again, you want to see if you have extravasation. All right, we're actually making pretty good progress. We're going on to toxicologic emergencies. Stuff's pretty exciting. So check up blood sugar. You can give them naloxone empirically. There's no downside. I thought that was pretty interesting. Like, all right, give them naloxone. Let's see what happens. Check thiamine B1 because it can cause beriberi. What are we talking about? Yeah, toxicology can cause beriberi, can cause chest pain, shortness of breath, can cause ataxia, get this Wernicke stuff going on. You can only do gastric decontamination if they present within 1 hour of ingestion. Wait, yes, unless, yes, yeah, okay. And blah, blah, blah. All right, so activated charcoal, I try to kind of make this sense from like an organic chemistry perspective. So I looked it up. Activated charcoal is negatively charged, right? Like a base. So it does not work on some things. So it kind of bonds to acids, but it doesn't actually doesn't work on acids. And I think like I guess if it's too acidic, if the pH is too low, it's kind of like out of range. It just won't do anything. It doesn't work on alkalis. That makes sense to me because those are bases. And if you give a negatively charged charcoal base and you're trying to bond to another base, that's two negative charges, that's not going to work. Metal makes sense. You need weird stuff to bond to metals. And we'll talk about like what we do for iron in a second. So yeah, you can't just throw charcoal or carbon at like lithium or heavy metals or something. So that's not going to work. It doesn't work on alcohol. This one I think is interesting. So the pKa of alcohol is like 16 to 18, which is like pretty close to water. And activated charcoal is just carbon, right? And you think about like what oil is. That's just carbon and hydrogen. Oil and water don't mix. Oil and alcohol don't mix. You can't use carbon to bond to alcohol. So you're not going to use that. And we'll talk about what we give to people for methanol and ethylene glycol ingestions in a second. And then you also can't use for like caustic agents. So that can be either acidic or alkali. So you can't use it. I think of like alkali again makes sense, but just like pH extremes. And then hydrocarbons, that one makes sense. Hydrocarbon is just a CH bond, like olive oil or like butter or something. You can't just throw more carbon at carbon and hope something's going to happen, right? So that's if somebody's ingested gasoline, which is a hydrocarbon, you're not going to give them activated charcoal. That's not going to work. What you do want to give them after the activated charcoal is a cathartic. So it's a diureal. So we're not going to digest charcoal, but it's going to bond to whatever we ingested. But you don't want that just sitting in the body. So you give them a diureal like sorbitol, which is actually the stuff in chewing gum that gives you an upset stomach. Or you can use magnesium, which is an osmotic laxative, and that's going to get that charcoal out of your system. Just give them one, don't dehydrate them. All right, gastric lavage, the old stomach pump, you can do in 1 hour. This. When you do have things like iron, lithium, heavy metals, but I think that it has to be like, I don't know, but you can give them polyethylene glycol, which is just Miralax. All right, you can use that for metal. So think of like they try to be like a rated R metalhead, but you gave them you got to bring them down to like a PG level. So you give them polyethylene glycol to help get that metal out. And you still have to irrigate. And then, all right, so what if you did ingest a strong acid that charcoal can't bind to, like salicylates, barbiturates, or INH? What you do for these, and I think they highlighted the word acid in all of these, this one does make a lot of sense. You just give them a base. They took an acid, you give them a base. You're going to give them the body's primary buffer. You're going to give them sodium bicarb. The cool thing too with the pathology of this is way in the weeds, but I thought it was pretty interesting because we talk about giving bicarb to people all the time. What happens, right? So bicarb is going to pick up the protons. Once you take a proton off of an acid, it's a conjugate base, right? So you kind of neutralize that acid. And bicarb becomes carbonic acid. And it's like, all right, well, what does the body do with that now? We actually breathe it out as CO2. I thought that was like crazy interesting. So this CO carbonic acid turns to CO2 and then we breathe it out. I'm sure we urinate some of it out too, but I thought that was pretty interesting. We want to get our patient's urine pH to 7 to 8 when we're doing this urinary alkalinization. Remember, though, that as we flood the blood with bicarb, the body will attempt to fix this by turning on the hydrogen potassium pump, and it kind of yeets out potassium from the blood, it's going to pull protons in, right? It's trying to fix that basicity. So look out for hypokalemia because the blood is going to be shoving potassium out of the blood to try to fix the problem of what we're already trying to fix. Okay. I don't know that I have to, well, whatever. So there's this whole idea with anticholinergics and sympathomimetics. I kind of talked about this before. I think what's really interesting with this is like back in the day when we were like cave people and it was late at night and you're like protecting your village and a lion or like a warring tribe or something comes closer to you. You're like fight or flight system, right? Your sympathetic nervous system starts going crazy because you need to like fight a lion or like protect your family or something. And it's dark out. So what do you need to do to see? You need to dilate your eyes. So, and I never forgot that when I thought of that. It's like it's fight or flight, you know, you're tachycardic, your blood pressure is going crazy, and your eyes are dilating so you can see who you're fighting. But the other thing is that your parasympathetic nervous system shuts down. Your rest and digest shut down. Do we need to move our bowels? No. So you get constipation. Do we need to eat something? No. So your saliva goes down. Do we need to cry? No. So your tear production goes down. So all of those things, the whole rest and digest shuts down and it's like all sympathetic. All right. So I'm just going to kind of read this. So cholinergic means the receptors involved with the neurotransmitter acetylcholine, kind of the poster child for parasympathetic nervous system. Cholinergic medications work by inhibiting acetylcholinesterase. So acetylcholinesterase is breaking down acetylcholine. It's breaking down the parasympathetic nervous system. A cholinergic is like acetylcholine, get in here. So it inhibits that acetylcholinesterase. So acetylcholine can survive and do its business. All right. I think of the parasympathetic nervous system as rest, digest, and cry on someone's chest because it's going to create tears. It's everything fluidy, right? So it's going to increase your saliva and tears. It's going to improve your gastric motility. It's going to clear your bowels out. And the rest means we're not up and fighting someone. We're relaxed. So our pupils are normal/constricted. Remember what we talked about with opioids earlier. Also, because we're like going to sleep, we're not fighting people. We're breathing slowly. So our respiratory rate goes down and our heart rate goes down. Now, on the flip side, when we talk about a sympathomimetic or an anticholinergic, and you think about why the presentation of these looks so similar, and then we'll talk about serotonin syndrome as well. So it's, yes, stop crying. You're about to fight somebody. So you get dry eyes, right? We're not going to waste energy on digestion, constipation. You're not eating right now because you're fighting a lion. So you get dry mouth. Also, we just shut off a neurotransmitter, right? Anticholinergic means acetylcholine, which is still a neurotransmitter. That's shut off. So we get confusion, agitation, seizure. Obviously, if this gets a little bit more severe. And then the sympathetic nervous system is going unchecked. So we do see tachycardia there. Sympathetic nervous is going unchecked. Oh, yeah, of course. Yeah, I'm sorry, we're talking about anticholinergics. Yeah, so you get tachycardia. So this is all you're up and you're fighting. And then we talked about this with the eyes as well, that your eyes get dilated because parasympathetic is shut down. Sympathetic nervous system is firing like crazy. Okay. We already talked about the meiosis with opioids. Sweating is the big difference here. With an anticholinergic, if you are shutting down the parasympathetic nervous system, you're not going to sweat, right? You're still going to be dry. However, if you are agitating or agonizing the sympathetic nervous system, you are going to sweat. That's the big difference you're going to see between the two vignettes, is going to be diaphoresis. The other one, just while we're talking about this, because serotonin syndrome can present similarly to an anticholinergic overdose and to a sympathomimetic overdose. In fact, serotonin syndrome also has diaphoresis. So don't tunnel in just because you see diaphoresis. But what's going to make serotonin syndrome unique is the muscle rigidity. So you get the altered mental status, you get the muscle rigidity, you get the autonomic instability, which you still get with this, but you're not going to get muscle rigidity in anticholinergics or sympathomimetics. All right. So that's a little explanation. We'll kind of go through these one at a time. So let's talk about cholinergics. So these are also called organophosphates. And I have here, right, an increase of acetylcholine, an increase of this parasympathetic nervous system. It's your rest, digest. It's also very wet and fluidy, right? You're going to cry, you're going to drool, you're going to pee, you're going to diarrhea, you're going to vomit. It's just all this fluid coming out of you. And this is what they used back in the day as like chemical warfare nerve gas. Because acetylcholine is still a neurotransmitter, right? So you get what they call this sludge. So again, salivation, lacrimation, urination, diarrhea, GI upset, emesis. But then you also get the killer bees here. So an increase in the parasympathetic nervous system, rest and digest overload. So again, bradycardia. The breathing one, I don't necessarily understand. I think because breathing is slowing down, you get bronchospasm. Bronchorrhea makes sense because everything else, you have all this fluid. So the additional fluid there is important. And then meiosis, because we're not up and fighting somebody, we're going to sleep. So your pupils are going to go down. They're going to let less light in. All right. You also get this, these nicotinic effects of muscle weakness and then respiratory failure. So again, we talked about breathing slowly. All right. Now the treatment for this, there's kind of two parts to this. Atropine is going to be the one that competes with acetylcholine. So again, you have this parasympathetic overload. Atropine is going to directly compete and get to the receptor before acetylcholine can get to its receptor. Also going to be great for bradycardia, right? But to actually fix the underlying issue, I think of acetylcholinesterase as like an air traffic controller that is pushing acetylcholine away, and somebody took out that air traffic controller. We need to get him back. We need to reactivate acetylcholinesterase. So we use what's called 2-PAM pralidoxime. You kind of just have to memorize that. That's going to be like the end all be all here. That's going to directly reactivate acetylcholinesterase, get rid of all this excess acetylcholine and fix the issue. Okay. They have seizures, you give them lorazepam. Okay, now on the flip side of this, rather than a parasympathetic overload, what if we shut off the parasympathetic nervous system? Well, what's going to do that? Tricyclic antidepressants are notorious for this. Antihistamines have anticholinergic properties, anti-Parkinson's drugs, and whatever the heck Jimson weed is. So these are going to competitively inhibit binding of acetylcholine. So it's going to keep acetylcholine far, far away. Parasympathetic nervous system gets shut down, right? Okay. Even I get confused with this because you really have to think about it's like anticholinergic. Okay. So remember how wet cholinergic overdose was? Very dry here. Hot, dry. You get these dry mucous membranes. Certainly not digesting, right? You get this hot skin. You're not sweating as much, right? Was there diaphoresis over here? There actually wasn't. Which is pretty interesting. Fluids coming out of every part of your body except for sweat. So again, you kind of keep that over with the sympathomimetic. Yeah, it's interesting. I never really thought about that. Anyway, here you get the opposite pupil response. So you get the mydriasis because the absence of parasympathetic activity means sympathetic activity. All right. Your eyes are wide open. You're fighting somebody. You get this flushed red skin, and then you get confusion, agitation, seizures, and delirium. We talked about that too, because we just shut off a neurotransmitter, right? We just shut off acetylcholine. All right. The treatment for this, TCA has its own antidote, which we'll talk about. If you see torsades, you want to give magnesium. Oh, but the antidote you want to know, it's called physostigmine. So that's going to be the antidote. However, you want to be careful because it can put you over into the cholinergic bucket here and mimic poisoning. So you want to use that as a last resort. All right, so now for sympathomimetics. So this is going to be things like, like Adderall, Ritalin, like amphetamines or like illicit amphetamines, over-the-counter decongestants, MDMA, ecstasy, Molly, cocaine, PCP, all the uppers, right? So you're going to look for that hypertension. It's directly stimulating alpha and beta receptors. It's releasing norepinephrine as well. So you're going to see hypertension, tachycardia, hyperthermia, and diaphoresis. That's the big one. All right. So you don't see that anywhere else other than serotonin syndrome. But diaphoresis here, mydriasis, again, sympathomimetic. We're up, we're fighting a lion. We need to see in the dark. So you'll see mydriasis. Primary therapy here is actually just supportive. There's no like antidote for that. Opiates, Narcan. If you give them too much Narcan, it can precipitate withdrawal. Nothing crazy there. All right, serotonin syndrome. We can see this in carcinoid tumors. Know about some of the meds that can contribute to this. I think tramadol is a really interesting one. That's like the opioid that's not really an opioid. Lithium is here. Amphetamines, cocaine, tricyclic antidepressants. That's a big one. That's going to prevent serotonin reuptake. So that's going to contribute here. So like I said, diaphoresis is here. Hyperthermia is here. Mydriasis is here. Sounds a lot like anticholinergics. Sounds a lot like sympathomimetics. But you get the serotonin syndrome triad. Altered mental status, still not unique because we had Mad as a Hatter. Autonomic instability. Yeah, there's already tons of nervous autonomic stuff going on. But muscle rigidity, that's going to be the unique one there. So look out for that. You don't want to use antipyretics when the temperature is up like this because the problem is not centrally mediated. So you can use cooling blankets. And then the antidote you want to know here is cyproheptadine. So cyproheptadine. All right, tricyclic antidepressants. A lot of stuff going on here. I think you need to know the antidote is bicarb. The pathology there is kind of cool. It like raises the pH, so it favors the neutral form of the TCAs, which is not toxic. Kind of cool. So I guess TCAs are pretty acidic. But I think the big thing here, tricyclic antidepressants basically have three buckets of what they do. One is they block acetylcholine. So you're going to get dry mouth, urine retention. You're going to get constipation because you're blocking rest and digest. Okay. They're antihistamines, so that's where you get some sedation. And then they block a bunch of like potassium and calcium channels and stuff. That's why you get so many cardiac side effects with this. I think the big one is QRS widening. GI, we talked about CNS, you got a bunch of non-specific stuff. But bicarb, knowing bicarb for tricyclic, I think is huge. Tylenol, the big one. Pathology here. There's normally two pathways, glucuronidation and sulfonation. I don't think that part's important. However, excess acetaminophen, right, in an ingestion is going to saturate those pathways and it activates a minor pathway. This minor pathway has a hepatotoxic product called, I call it NAPQI because QI is like a Qi charger, a wireless charger. So NAPQI. Now with limited amounts, this glutathione comes in, breaks down NAPQI. Okay. However, we're overflowing this minor pathway, or honestly, I think just stimulating it a little bit. Glutathione is going to be depleted very quickly, and NAPQI is going to wreak havoc. There's these three stages of acetaminophen toxicity. I think it's important to know stage one is what happens within the first 24 hours. The symptoms aren't specific, so you have to be really important with taking your history here, because that hour is really the only time you can give the antidote, right? I think the best time isn't it like within 4 hours? Oh, 4 hours is ingestion. Within 8 hours is going to be 100% effective. So after 24 hours, you can't give your antidote, which we'll talk about in a second. Stage 2, which happens after that 24-hour period, that's when you're going to see LFTs. So if you take the patient's labs and the LFTs are already elevated, you've kind of lost your chance. It's pretty scary stuff, right? However, if the patient comes in and they just took 6 bottles of Tylenol 2 hours ago, you can't take their blood until 4 hours of ingestion because I believe it just takes that long to metabolize, and you can't get a true level of how much they actually took until 4 hours. You kind of have to let them wait. All right, treatment, you can do activated charcoal if present within 4 hours. So if you catch it real quick, you can use charcoal. N-acetylcysteine is going to be our antidote here. Within 8 hours is like the golden window. And just keep that in mind with like the 4 hours after ingestion, how long that might be on a vignette. But within 24 hours is still fine. What NAC is, it's a glutathione precursor. So it's going to refill your glutathione tank, get rid of all your NAFG. All right, salicylates is a pretty interesting one. You're going to see this in things like Bengay, Pepto-Bismol, oil of wintergreen. All right, so it stimulates your medullary respiratory center, resulting in respiratory alkalosis. So what type of breathing would result in respiratory alkalosis? Slow breathing, right? Yeah, rapid breathing blows off. Wait, no. Rapid breathing. Yes, rapid breathing. Yes, rapid breathing blows off CO2 and causes respiratory alkalosis. So salicylate starts with S equals slows your breathing. However, they also uncouple oxidative phosphorylation, our friend, the electron transport chain, which is powered by this proton gradient. Remember, it's like this proton gradient, oxidative phosphorylation. It's making all that ATP. Salicylate overdose uncouples all of that. The proton gradient that was powering that ATP pump breaks, all the protons go all over the place, right? Protons or hydrogen ions are what contribute to acidity. So that is why you get your anion gap. That is why you get your metabolic acidosis, because of the uncoupling of oxidative phosphorylation. We've talked about acidosis so often, but to actually see the pathology there, I think is actually really interesting. So you get the mix. You get the respiratory alkalosis because what is happening? Because you're breathing quickly, but then you also get the metabolic acidosis because of all the protons, okay? One of the other early signs of salicylate toxicity is going to be sensorineural hearing loss. And then a late sign is going to be hyperthermia. Yeah, late sign is going to be hyperthermia. The treatment for this, and salicylate, which is salicylic acid, this one makes sense. It's just going to be bicarb. So you give them an initial bolus, and then you keep them on a continuous IV drip. I don't think they're going to be good to go home for quite a while. Beta blockers, just know you give them glucagon. Calcium channel blockers, just know you give them calcium, or you can give them glucagon as well. All right, toxicology 2. I'm going to take a break. This is taking a long time. I will be back.